Hi everyone, we are Team 1H. Today we'll talk about the Netherlands health system.
The Netherlands is one of the richest and most urbanized countries in the European Union. GDP per capita reached around 60,000 euros in 2023, far above the European Union average, supporting universal health coverage and a life expectancy of about 82 years. Our deposit analysis highlights four major contextual factors shaping the Netherlands health system. First, the Netherlands is rapidly aging. Over 20% of the population is already above 65, rising to 25% by 2040, which increases chronic diseases, long-term care needs, and workforce pressure. Second, 89% of deaths come from non-communicable diseases. Outcomes are strong overall, but mental health is worsening. Around 20% of adults report disorders, and waiting time often exceeds standards. Third, European Union policies such as EMA regulation, GDPR, and the upcoming health data space strongly influence national governance, alongside domestic reforms like the ICA. Fourth, although digitalization is advanced, weak interoperability limits the impacts of digital health tools. From this context, we assess performance through 5 goals: ensuring physical sustainability, improving access to primary and community care, strengthening prevention, securing a sustainable workforce, and promoting integrated, regionally coordinated care. At the same time, the system faces 5 major challenges: severe staffing shortages, rapidly rising long-term care costs, overloaded primary care, worsening mental health and widening inequalities, and ongoing digital fragmentation and medicine shortages. These tensions together define the key pressure points shaping the future of the Netherlands health system.
Building on the challenges just discussed, I will now move on to how the Dutch health system actually performs. This slide shows the system's operational performance across several key dimensions. Overall, the Netherlands perform very well. Patients are highly satisfied, especially with primary care. But high long-term care spending continues to put pressure on sustainability as the population ages. Financial fairness is more mixed. Out-of-pocket payments are low, which is good, but the deductible is regressive, meaning low-income groups feel the burden more. Responsiveness is generally strong, though mental health waiting time remain above national norms, and both income-related and regional inequalities still exist. The next slide, we compare the Netherlands with Germany, Sweden, and the UK, countries that already perform strongly in Europe. The Netherlands holds a competitive position. Life expectancy is high, infant mortality is low, and overall population health is strong. In terms of the spending, the Netherlands invests more per person than UK and Sweden. That doesn't mean inefficiency. It reflects a deliverable choice to maintain high quality and accessible primary care. At the same time, spending as a share of GDP remains moderate, so the system is still relatively sustainable. Finally, potential years of life loss places the Netherlands in the middle range, showing good outcomes overall, but still some room to reduce preventable deaths through earlier intervention. So overall, the Dutch system delivers strong results and high satisfaction, but still need to improve fairness, mental health success, and regional equity.
This is the Dutch healthcare system overview. First of all, governance follows a tube-type model. National bodies set policy and regulate insurers and providers, while local actors deliver services. Although regulation is centralized, implementation is decentralized. Next, healthcare, long-term care, and the social support each operate under separate laws and funding streams, creating parallel governance structures and occasional coordination gaps. Responsibilities are split across insurers, municipalities, and local authorities, resulting in strong national policy but fragmented delivery. Long-term care is governed by 4 acts: the Health Insurance Act, Long-Term Care Act, Social Support Act, and the Youth Act, which together define how care is funded and who provides it. Now, let's look at the organizational structure. The Ministry of Health sets national policy and is supported by advisory bodies in the National Healthcare Institute. Insurers sit at the center. Everyone must buy basic insurance, and they fund care by collecting premiums and purchasing services. Regulation is shared between 3 bodies: the Authority for Consumers and Markets, the Dutch Healthcare Authority, and the Healthcare Inspectorate. Providers deliver care at the bottom. Orange arrows show oversight and information flows, whilst the green arrows show financial flows, which run from patients to insurers and from insurers to providers.
Now I'm going to discuss and focus on how the Dutch healthcare system is financed and how that mix has shifted over the last decade. If you look back at around 2013 to 2015, roughly 4/5 of all health spending was already funded collectively. In 2013, this 80% of shift happened when the healthcare expenditure came from public or compulsory sources, with the remaining 20% from private insurance and out-of-pocket payments. Within that collective part, about 46% of the healthcare funding flowed through income-related payroll contributions and 22% through general taxation. So roughly 2/3 of the money going into health was tax-based or social insurance-based. Fast forward to a decade, the system has actually become a bit more collective, not less. By 2021, 85% of the health spending was financed from public or compulsory schemes, and out-of-pocket payments made only 9% of the total spending, which is a significant decrease. And it's well below the EU average. In 2024, total spending rose to about 113 billion, roughly 10% of the GDP. And this increase again was driven by public and mandatory insurance funding rather than private top-ups. Why did the public share creep up? Firstly, COVID led to a sharp one-off jump in public funding in 2020, while private spending actually fell as non-COVID care was postponed. Secondly, the Netherlands spends a large chunk of its budget on long-term care, and that sector is predominantly financed from taxes and social insurance. And thirdly, policy has deliberately kept deductibles and co-payments bounded, which limits how much of the system can be shifted onto patients' wallets. So overall, the financing mix today looks slightly more solidly collective than a decade ago. The state and compulsory insurance still carry out most of the cost, private insurance and out-of-pocket payments play a supporting role, and financial protection for Dutch residents remains very strong.
So now let's briefly walk through how the Dutch risk pooling system works. Everyone contributes, employers and individuals, and all the money first goes into the National Risk Equalization Fund. From there, funds are redistributed to insurers based on needs, not on profit. So the whole idea is simple: share risk fairly and make sure no one is disadvantaged because they are older or sicker. The most important part is the risk adjustment. It uses factors like age, gender, and other conditions to estimate each insurer's expected cost. If an insurer covers a higher risk population, they automatically get more money. This stops claim scheming and adverse selection. And overall, this model delivers universal coverage, strong financial protection, and one of the most equitable insurance markets globally.
Let's look at resource allocation and provider payment. The Dutch system demonstrates strategic resource allocation by dedicating 28% of its budget to long-term care, establishing clear service priorities across different care levels. Hospitals receive diagnosis-based payment that control costs but risk resource concentration, while GPs operate under a blended payment model. A key achievement is the exemption of GP services from deductibles, contributing to exceptional equity with just 0.3% reporting unmet medical needs in 2024, the EU's lowest rate. However, challenges include GP workforce shortages due to inadequate workload compensation and constrained facial flexibility from the substantial long-term care commitment.
So let's move on to the health service delivery. The Dutch health system covers almost everything, with only few exceptions like adult dental cares, alternative medicines, and aesthetic care. More than 95% of the Netherlands population has a GP who act really to ensure that every patient works with their healthcare teams on shared goals and given them the access to more specialized care. Workforce remains a big challenge for the Netherlands health systems, with over 260,000 employees that's projected to be missing by 2035. Government has tried to tackle this problem by giving nurses more autonomy, allowing them to prescribe certain drugs and perform small amounts of procedures. On the other side, pharmacists are still not allowed to prescribe independently. Quality of health service in the Netherlands remain one of the best of all OECD countries, with a small breach in the immunization coverage. To finish, here are a few recommendations. To help workforce, we want to open regulation to allow immigrants with healthcare training to be part of the workforce. To improve the quality of care, we want to introduce a motivational interviewing program to boost the immunization rate, and we want to respond to the funding pressure by assuring that we empowers the leverage of European Medicines Agency to make sure that the cost of new drugs will remain low.